Trojans Talk Research is a monthly spotlight on the research interests of choice faculty presented by Troy University's Office of Sponsored Programs. This month features Dr. Teresa Johnson talking about how her clinical observations and subsequent research completely changed her mind about how to feed patients who require tube feeding.
So I want to talk a little bit today about what I've been doing the last 14 years with some colleagues, and that is blended tube feeding. So a little bit about me. I have a BS in dietetics from the University of Montevallo, a master's from Auburn, a doctorate in clinical nutrition from Rutgers, and then I have worked for 36 years as a registered dietitian, and about 34 of those years teaching part-time, full-time. I did quit clinical practice a little over 2 years ago, right at the end of COVID, to care for my aging in-laws and parents. And as a notice, I am a paid speaker for several pharmaceutical companies. So I want to give you a little bit of background about tube feeding. How many of you have ever seen a tube feeding? Nobody. Okay, well you will today. This is where you bypass the oral feeding because somebody's not able to chew or swallow. We had a lot of that after COVID with the intubation, and people couldn't, they had to get their swallow ability back. And so sometimes it's temporary, sometimes it's forever. But we had a hard time doing that, feeding people who couldn't eat by mouth for most of human history. In the olden days, they tried to feed people through whale bones covered with eel skin. We had a president who was shot and was fed over a month, rectal feedings of wine and beef broth. And yeah, until the development of the blender and polyurethane tubing. Tube feeding was not really feasible, but now, because of that, we can feed people other ways. So 1940s and 1950s with the development of the first feeding pump at the Henry Ford Hospital. And what they did is there was no formula. Have y'all seen little boxes of formula? Maybe Pediasure or Ensure, maybe you've seen commercials for it. Okay, they sell some of this stuff at Walmart and pharmacies, but before that, hospital kitchen staff would blend food. They would put it in a tube feeding bag and deliver it to the patient. Many times they would deliver it with syringe. They would draw it up, they'd pop it in the end of that tube, and then put it right in. In the very first tubes, they were nasogastric. So they would take the tube down into the stomach and go that way. And they were pretty large and uncomfortable, but then by the time the 70s and 80s rolled around, they were putting gastric tubes in, which were much nicer. So 1970s commercial formula came along. They said, hey, this is better than giving people food because it won't clog the tube, it's sterile, we know exactly what's in this box. But what is in this box? It reads like a science experiment. It's really, really long, all these additives, and it's probably the most processed food on the planet. But we were taught in school, you don't put anything in a G-tube or a tube feeding except water, medications, and sterile formula. And that's what I did. But about 20 years ago, we began to see a patient groundswell. What's that message us dietitians are always telling people? Eat plant-based, eat a variety of food. Well, it's reached the tube feeding population. And we have a lot more people who are tube feeding at home. The home enteral nutrition patient population has mushroomed and ballooned, and so people were just putting things in their tube, and hey, you know what, we feel better, we're doing better with this, and so they started doing it, even though dietitians told them not to do it. I'm just going to show you a clip. This clip is probably 15 or 20 years old now, but it's funny. It was done by someone who went to a dietitian trained like I was and got the cold shoulder. And again, I won't play the whole thing.
My son seems to not be tolerating his tube feeding formula. He keeps throwing up and his poop is all wrong. I want to change him to blended food because I have heard that it can be awesome.
Maybe you are feeding him too fast. We could try slowing down his feeds or putting him on a pump.
I'd really like to try the food thing though.
If he still doesn't adapt to the formula, well, we can try another one. Or maybe his doctor would prefer he got a J-tube instead.
Did you hear me? I have been reading about using real food and how it has helped so many people. It seems like common sense to me, just blending up food. Will you help with the diet plan?
No, I'm sorry, I can't help you with a diet plan. Why would you want to do that when formula is the best thing for your son?
I am starting to think that formula is not the best thing for my son. Also, I think food is what people are meant to eat. Since you're a dietitian, I thought you might be, into that.
Anyway, this is hilarious the more it goes on, and I won't subject you to it, but this is basically what happened. This is a movement among patients and caregivers to say, hey, we don't want this. And they had to swim against this tide. And a lot of people do it, undercover. They don't even tell their physician or their dietitian what they're doing.
Right.
So my journey, where did my journey begin? So about 14 years ago, I got a call from a dietitian over in Auburn at one of our feeding clinics, because I've worked pediatrics about 30 years, children with developmental disabilities, severe ones like nursing homes and outpatient clinics. And we had feeding clinics and genetics and seizure and ortho, and seems like every other clinic you could do. But we had this little fella named Tripp, and by the way, I do have permission to say this, okay, if I have talent release for him. He was born with bronchopulmonary dysplasia and was taking a bottle, and BPD makes it really hard to breathe and takes a lot of calories to breathe anyway. And as he got a little older, it took more calories than he could take by bottle. So we tried feeding him, and finally we just said, hey, you know what, at night we're going to have to start a little tube feeding on him to supplement what he's able to tolerate in the daytime. And as soon as they popped that tube in, he got so sick. They did 2 fundoplications, changed formulas, medications. This went on for months. And he was losing weight, falling on the growth chart. And Dr. Google came along to the mom, and she said, hey, I saw on the internet that perhaps if I put could we try food? Thankfully, the dietitian that day in that feeding clinic at Auburn said yes, because we had been very frustrated and very eager to help this little boy. And so that day in feeding clinic, that we opened up a jar of baby food green beans, popped it in his formula, put it in him, and he did not gag, retch, vomit, anything. Now remember, he had been taking a bottle and eating some baby food. He had stopped doing that because he associated eating and feeding with pain, and was down to just 25 cc's an hour. So, but after that, he got a whole lot better.
Can I ask a quick question?
Sure.
Help an old guy. How long ago was that you did that?
This was 14 years ago.
Okay, thanks.
Let's see if I can. Love the music.
I use this large bolus. We have this extension.
I want you to see a tube feeding.
You want me to feed you some? Are you hungry? You need a little snack in your tummy? We can do it. This is a little snack bottle I've done for him.
Sneaky snack.
And it's got almonds and some gluten-free cereal. It's got coconut milk and coconut oil, banana and avocado, apple juice.
And all that mixed together.
All that mixed together in the blender. Open his little button. He's a good helper. Lock that. Unlock that. And we push it in slowly. Now, used to when he was little, I would have to just barely move it like that. But now he can tolerate it so well that we can just push it down like that, and then you clamp it and undo it. And then he closes it up. Good job.
And Tripp, we want to know how you feel. Are you happy now that you can eat the same foods that your sister eats and your classmates?
Yes.
What are your favorite foods?
I don't know.
What do you like to eat? What do you ask Mommy to make you all the time?
Macaroni and cheese.
Mac and cheese. What else?
French fries and ketchup.
French fries with ketchup. You like to dip? What else?
I'll stop that right there, because you can see, imagine, little baby, not eating, couldn't even get near him with a bottle or a spoon, and we were able to get him back eating orally. So that's the goal of our feeding clinics. Now remember, I've been trained not to do this. 1985, 86, got a job at Jackson Hospital, Montgomery. First day on the job, I walked up to the 5th floor and I saw a bag of green, brown, yellow stuff sitting on the nurse's desk. Didn't know how long it had been there, didn't know what was in it. They were getting ready to take it down the hall and feed it to somebody, and I said, oh no, that's not what we do. And I got rid of it. So after this experience, I had to repent in sackcloth and ashes because I realized that maybe that wasn't the right thing. And I thought of so many children that maybe I could have helped over my career had I been open to this or had known about it. But it's how we were trained. Every policy, hospital policy, no, you don't do this. So I'm lecturing on this actually in my basic nutrition class, just so students can see what a tube feeding looks like. And sitting in the back of the room, a young man became very emotional. And I thought, uh-oh, I've done something wrong. But after class, he came up and he said, Tripp is my neighbor. And this is what he looks like today, or at that time, in 2022. He's doing great. And I really believe, and his mom says this, blenderized tube feeding saved his life because he was about to have to be on intravenous feeding, which you can't do that forever, right? It messes up your liver. So that turned me around. And I would encourage all of you students, as you move into your careers, have some academic humility. Maybe the things that we're teaching you today will be challenged in the future. Go with it, all right? Listen to your patients and listen to your clients. So that was my journey. So what we did is we published that case study because I had not seen anything like that before. And that came out back in 2013. And we were able to wean him from the tube feeding, and as you saw, he's doing great. Well, then we decided, I wonder if other dietitians are doing this. What's it like around the world? So a little academic inquisitiveness also helps. As you guys enter your careers, don't just be consumers of information. Look for opportunities to contribute to it as well. So we decided to do a survey of pediatric dietitians, because that's where we were working. And this was national, and we got 242 respondents. And we found, amazingly, over half did see it in their clinical practice, and they recommended it. The majority reported positive outcomes, and the main reason was parent request. Again, what we saw, this is driven by parents looking for answers. Now, the RDs who were surveyed, the reason that they did not use it was formula safety. They were like me, they were concerned about what's in that bag, we don't know. What about support? You know, it's against our policy here, everything that we had also experienced. As a matter of fact, we had to publish this paper without the knowledge of our supervisor because it really was frowned upon. Then we decided to look at parents, and so we found a parent group of just tube-fed children. It did not specify blenderized tube feeding, any type of tube feeding, and we got 430 responses. Interestingly, it was a very, almost a picture-perfect, from a statistical standpoint, data set. Half males, half females, children that these parents took care of, had a good distribution on the age and so forth. But the reasons that they gave for using blenderized tube feeding, they wanted something natural, not processed. Again, they'd heard the message. They wanted to use it as a bridge to oral feeding. Believe it or not, when you have a tube feeding, you can taste that. You can smell that. And so if you put food in there, guess what? You can sort of taste it in your mouth. You can smell it. It can get the child interested in eating real food. Then reduced tube feeding intolerance. That was our third reason. Allergies, because sometimes you can't find a formula that's missing the ingredient that's offending the child. Less expensive. Now that was another one we thought was interesting because insurance companies don't pay for blenderized tube feeding. Many times they'll cover this. But because there were less medications, less trips to the hospital, and in some cases they didn't cover enough formula, many parents said it was cheaper to go the route of feeding. My concern, the growth goals. You know, in children we want them to grow, and more families who were using BTF reported that their child was meeting their growth goals than those parents of children who were on commercial formula. My main concern, though, was that of those who were using BTF, less than half their diets were being followed by somebody who could say, hey, you might be missing this, or you're on this medication, we need to look and make sure you're getting enough of that. That was a bit of a concern. We asked them why, and they said, well, they didn't feel supported. So this is back in 2017. So we decided, all right, we've got to get the word out, and we've got to get it to other practitioners. And so we wrote a review article, got it published in the American Academy of Nurse Practitioners. And this is where a lot of times you'll hear professors talk about interprofessional health education. You need to know, SLP needs to know this, OT, dietitians, nurses, physicians, therapists, everybody on board, because it may be something they haven't heard of before. We've actually had cases, unfortunately, where the police were called. DHR was called to families who were blending food and putting it in their children's tube because it was just so anathema to healthcare. And so we began to branch out to inform RNs of BTF use, efficacy, and safety, and we published in this particular journal. Then everybody had this problem with safety. Safety, safety, safety. We're afraid it's going to grow bugs, and we don't want to put that in somebody's stomach. I said, all right, let's look at the literature. We did a really good deep dive on the published literature of bacterial load of blenderized tube feeding. And what we found is all the papers, every single one of them, had been published in a third world developing country. Philippines, Saudi Arabia, I can't even remember all of them now, South America, Central America, because they don't have a lot of formula down there. And when they do, they don't have insurance coverage, okay, so they have to rely on it. We also found in those studies methodology was flawed or not there at all. For example, one bag of blended food in one study hung for 18 hours. Would you eat a plate of food that had been sitting out for 18 hours at room? No, you would not do that. But yet, I guess they figured it's in a bag, it's okay. No, it was not. So we said, you know what, we should do this, we should do a study like this in the United States. And so we did. We went over here to Troy Regional Medical Center. Mayo Clinic sent us one of those Vitamix blenders. It's like a wood chipper, okay? It will really blend some food. And went down to the hospital kitchen, and we blended a recipe that was produced by University of North Carolina, Chapel Hill. And you say, why did it have to be produced? Because there are certain things that do well in a blend and some things don't. You know, bread will gum it up, and you don't want to put celery in there, it's stringy. So they had these recipes that they had already worked through all those problems. And we made that. We put it in a collapsible feeding bag. Then we made one out of baby food. If you don't have those expensive blender, you can take baby food and mix it up. And then we took just some of the routine hospital formula in a third bag. We took it up to an empty patient room because we wanted to simulate a feeding at ambient temperatures in a hospital, not in an unair-conditioned room in the Philippines. And so we began to run that. We collected samples at baseline at 2 hours, and one of the rules is you can't leave food out for more than 2 hours. So we took it at 2 hours, but then we decided to violate it and do another collection at 4 hours to see if there was growth. We did this 3 times. So we repeated our experiment 3 times. And the biology department here at Troy, they were wonderful. They ran all the plates for us and helped us with that. And every one of those plates, 150 plates, equally safe as a Tetra Pak of sterile formula. Challenged every paper published to date. And then somebody said, well, you said earlier most people are doing blenderized tube feeding at home. What about the home environment? That's a great idea. Let's look at it. So we found 50 volunteers around the Troy area to say, hey, we're going to bring you a meal kit. Because that's when meal kits were kind of popular. People were getting them delivered to the door, HelloFresh. And so we'll deliver you a meal kit and some instructions on how to, just basic things you would expect at home, how to clean your dishes and air dry them and all that. And you make this blend and we'll come pick it up. And that's what we did. And we did that for 50 samples. And out of all 50 samples, we had one that was slightly above 10 to the 5 colony forming units. Now the cutoff is 10 to the 3. If anything's 10 to the 3 CFUs, that's considered safe, and that's very strict by international standards. And that's okay, we don't mind being strict. No presence of coliforms or whatever. So just one sample. In that particular home, they were renovating, and there was a cat in the kitchen, so I don't know, but the biologist here at Troy got a little curious. And so she decided to look at the food that was in their kit. We used UHT milk. Does anybody know what that is? It's ultra high processed, like it's shelf stable. You don't have to refrigerate it. So it has a long date before it expires. It was 6 months out, and she found a little bit of bacteria in that UHT milk. I would have thought that would have been the cleanest thing, because we sent broccoli and blueberries and other things that I thought might have been contaminated, but not that. In any case, we can't tell where it came from, but only one, and only slightly. So today when you guys go eat lunch, your food may be 10 to the 6, 7, or 8. All right, so we felt like maybe the standards for Tetra Pak formula might be not the risk to benefit. Okay, what's the benefit of giving a sterile formula, and what are we missing out on here with our patients? So our conclusions were that if you use established, accepted, safe food handling procedures that most of us grew up, you can keep that bacteria at a low amount and people will be fine. And up until that point, there was not a single published paper showing anybody got sick from doing blenderized tube feeding, from foodborne illness. That changed this summer. Dr. Gina Rempel was telling me the other day, she's from Canada, she's a pediatric gastroenterologist. They allowed a family to bring in some BTF that they made at home and give to the child in the ICU, and she did pass away from Bacillus cereus infection. So now I can say there is one case out of I don't know how many. So it is important to make sure that good procedures are followed. Well, this is when we really decided to put it to the test. Patients that are very difficult to feed, adult patients, patients with head and neck cancer. So I went to my oncologist and I said, hey, would you let us do this? Because in at the Montgomery Cancer Center, they go ahead and drop a tube in everybody who's about to get chemoradiation because they figure they're probably not going to eat. Some facilities, they wait until they see how the patient's going to do. But there, they drop them, what we call prophylactic tube feeding, rather than a reactive. And so anybody that wanted to participate, because we didn't want to randomize, we knew there'd be benefits. So sometimes it's not ethical to deny treatment. And I mean, RCTs are great, but we had so much evidence to show benefit, we said, hey, if you want to enroll, we'll enroll you in this. And here was the idea. Most of these patients get chemoradiation for about 8 weeks, and then they have to take them off and let them get a break because it's tough. And most of these patients will drop 10, 20, 30 pounds in that period of time. So they, to ease the doctor's minds, we said, look, we'll put them on the standard formula, and then 2 weeks in, let us give them this real food blends in a packet. Now, Mayo Clinic had done a study like this before, but they took blenders and recipes to the patients. Well, if you've got head and neck cancer, you don't feel like cooking. Okay? I'm a cancer survivor. I didn't feel like cooking. And so we thought, well, we'll take that same study, but we'll use a product. So I met the lady who started this company, and on a handshake, she said, yeah, I'll help you out. And so she sent $80,000 worth of product to my garage here in Troy, and we would take it up to the hospital and in the cancer center, and they would give it to the patients. That was better than mailing it to the patients, because if they're sick and they don't take it, you won't know. And the dietitians up there kept up with them. So at the end of 2 weeks on regular formula, the idea was to replace 2 of these with these. That was it, just partial. And then at the end of 4 weeks, go back to this, so I could run the ANOVA, right? And we were going to get to 30 and all that. Well, then COVID hit. And it made it very hard to follow the patients. And I'm a purist. If we didn't follow the patient all the way through, I did not include them in the data set, because we enrolled plenty of patients. But some of them would have to go to the hospital policy, you can't feed that here. Or maybe they didn't need the tube feeding for the whole time. Or some passed away. So it was very hard to get even the 16 that we collected over 2 years to the finish line. But this was what was amazing, y'all. We had to go back and amend our IRB. Because once they started on this, not one person wanted to be partial. They wanted to stop taking this, and they wanted all this. The second thing that happened is at the end of the 4 weeks where we were supposed to observe them on the blend, nobody wanted to go back to commercial formula. They felt so much better. So we had to amend, get more product from Jennifer, and keep going. But they said there was less pain, vomiting, gas, bloating, nausea. And remember, these people are getting chemo radiation to their head and neck, and they're reporting less side effects from the toxicities of those treatments. It mitigated weight loss, unheard of in this patient population. Most of them lose massive amounts of weight, and it'll get really bad at the end of the second week, and then once they get off the chemo, it may take up to a year to regain back to baseline. They had better quality of life. They were eating more by mouth. They were taking more of their supplements. Very hard to get these patients to do it. And this tells our story. This has made me famous. It's made our team famous. You can see here the weight loss. Come over here. So they got their tube, they started their treatments, and they put them on formula, and the weight starts declining. And then in the middle of week 3, we transition them, out of pack, until we get them completely, the beginning of week 4, they are on 100% food, and their weight went back up. By the end of it, they were back to baseline. It's unbelievable what we saw. Challenged all of our conventional thinking. And if you want to see the whole poster, it's over in the KHP department, hanging above the refrigerator. But that really tells our story, along with everything, all the other things that they reported. Let's see. Well, we had a company approach us. Our lovely Troy people, they put things in those weekly announcements that come out, Cliff, and I'm so appreciative of that because apparently companies troll the internet looking for things. And there was a company, You Deliver Medical, out of one of the northern states, who contacted me and said, hey, I see that you're into this type of research. Would you do me a favor? We have a doctor at Boston Children's, it was Boston. He won't use these tube feeding bags because he says you can't clean them. He only wants us to syringe feed blenderized tube fed little children with these. He said, would you test these to see if they can be cleaned? Because we need third party testing. So again, I called on my biology friends, my nursing friends, my colleagues, and they said, yes, we will do that. So we made BTF in our homes. We reused these bags just like the manufacturer said. We drew them up. We did mock feedings. Then we took them over to the lab here at Troy, and they did surface testing. There are no standards for surface testing. That was another problem we had. And but our microbiologist was very diligent and found something we could use. And we found these were just as clean. Because he was thinking you couldn't clean in all these little corners. So that was amazing. That was a really nice study. And it's an example of how your research can inform industry and make some changes there. The next thing we wanted to challenge was the patient population group that I had worked in for decades. Medically complex children with severe developmental disabilities. Now, I told you I'd kind of gotten out of that. I was working in rehabilitation for adults, but I have a colleague out in Colorado, and I called her and I said, hey, you do this every day. She sees kids from birth to 36 months. Would you like to do a retrospective study? She said, well, it was all through COVID. I said, but that's a good thing. The kids were home. That way we know that they were not impacted by being with other children and getting sick and being off their tube feeding. So it was a perfect thing to do. And so we did a retrospective chart study. They were not cherry-picked. Went back, took 30 kids, medically complex, who were transitioned to a BTF at some point in that 36 months. And we wanted to compare their growth curve. What we found, reductions again, GI symptoms, but look at that GI meds. Most of them were on 4 or 5 GI medicines at the beginning. By the time they were transitioned, many of them were on none or only 1 or 2 for their stomach issues. It's incredible. They also grew and they improved. We got student help, by the way, on this one, and we tried to do growth velocity before and after, and we found we couldn't do it because in these kinds of children, their growth velocity just cannot be compared to what we would expect, okay? And so then we decided, well, what if we looked at the kind of blends that they got? There's some blends out there that are 100% food, and there's some out there that's partly formula and part food. Well, it didn't reach statistical significance, probably because we couldn't follow them very long, but we found the ones that were on the least processed, they did the best. But again, not clinically significant, probably because of our number and our time to follow. Now, this leads us to the next paper. We had a little child in that group that was being fed in his jejunum. So mouth, esophagus, stomach, just below the stomach is your jejunum. We don't normally introduce food there because it's kind of like dumping. You know, all of your food just dumping in there. It makes you very uncomfortable. But sometimes if you don't have a working GI tract, we can try feeding you there. It's called a J-tube feeding. And this kid was getting food. Oh, you sure don't do that in clinical practice. You give him something that's sort of already broken down. He was doing fine. So what we decided to do was, again, survey dietitians. Have you had patients who were putting food in their J-tubes? I suspect that many don't know, because the dietitian up at Mayo Clinic that we work with, Lisa Epps, said that she had a J-tube patient in her list of patients she saw, and she said after about a year, she said, "You're doing so well. What is it that you do?" And he said, "I don't do anything you tell me." And so she put her pen down and said, "Tell me what you're doing." He was blending food and putting it in his J-tube. So she was very interested in this study, and she helped us with it. And so we sent this 23-item survey out to every dietitian we could find in North America, and we only got 15 complete responses. I feel like they don't know their patients are doing it. Of the 15 responded who said, "I have had patients," or "I have patients now who are doing this," same thing. Better outcomes, reduced problems. So that is really challenging conventional wisdom. We decided to try to publish it in a very good journal. They rejected it. I just don't think they could deal with it. They just didn't want to say, "Hey, yeah, go ahead, y'all start putting food in J-tubes." But Topics in Clinical Nutrition did accept it. Not as a highly esteemed journal, but that's okay. We want to get the word out, and it is indexed in PubMed, so the word will get out. But that led to another idea. How many facilities are preventing dietitians from doing this? They know it works. What are policies that are going on? So we decided to do a policy study. We sent out all over the country. We actually contacted the formula companies that I speak for and said, "Hey, on all of your clients that you advertise to, would you send them this little survey and ask them about, do they have a policy, a hospital policy about blenderized tube feeding? Does their policy allow it to be made in the kitchen? Does it allow for something on your formulary? What's the formulary? Well, I go see a patient and they're diabetic renal and they need a tube feeding. Well, I can open up this book and say, oh, this is the product we use for a patient who needs a tube feeding, who's diabetic and has kidney failure. Or maybe you have a patient with liver failure. What formula do you, because there's like hundreds of different kinds of formulas that you can use. So do you have a food-based formula that you can feed patients, commercially prepared? Because formula companies do make these now. They didn't forever, but now they do. And are you using that? Or do you allow people to bring food in from home? What is your policy? Do you train your staff on to do this? Are there recommendations for hang time and refrigeration time and handling the formula? And we have the data now. We're in the process of writing the paper, and what we found is only about half the hospitals even have a policy, which I was surprised that many had one. And of those, I would say almost all of them are incomplete. So this will be a very good paper. We want to disseminate that and say, hey, y'all need to write some policies. Either say we're against it and come up with something to offer families who come, figure out what you're going to do. The Oncology Center in Nebraska reached out to us when I gave a talk about our head and neck cancer paper. I would venture to say at least 30 presentations on that one paper. And they reached out to us and said, hey, we'd like to repeat that study, but the oncologist wants to randomize the patients. I'm like, okay. It makes you nervous when somebody replicates your study because there are nuances of head and neck cancer patients. When we first started, we were just giving everybody formula, And then we realized that you probably didn't need to try to do this with non-compliant patients. As I said, we didn't cherry pick, but if you've got people who say they will do and they won't do, that's not the good people to keep in your study. So I'm curious to see what they find out. I called the lady last week and she said, we finally got to enrollment. So we are enrolling patients and they're very big, so they will get a statistical number they can do a lot with. And then our next study that we want to try to do here on Troy campus is say, hey, I'm gonna go to the hospital, I'm gonna pick up some random trays, and I'm gonna see what the CFU is. How dirty is hospital food? And I say dirty in air quotes. I don't think it's dirty, but how well does it compare to the standard that we place on our formula-fed people? So what are some research journey highlights? Well, first of all, an observation from clinical practice led us to challenge conventional teaching and thinking. So I would encourage you all, have an open mind. Don't take everything that comes, use critical thinking and your judgment skills. It also led us to challenge how we did clinical practice and change policies. We also engaged numerous stakeholders across academic practice and corporate venues. Think of all the people I've talked about who've been involved with us. Troy colleagues, Dr. Mundi and the dietitian Lisa Epp at Mayo Clinic up in Rochester, Sharon Weston, who is the dietitian at Boston Children's, Catherine Bennett at Children's of Orange County Hospital in California, Shauna Walker again out in Colorado. All these people have helped us, have come alongside, have partnered with us to do these studies. We have dietitians at pharmaceutical companies and many others, even our Troy students have participated. So here's Taylor. She worked very hard on that cancer paper with us. So Sydney Elston went up there and helped as well. They're both dietitians now, doing quite well. So it was really fun to work with other people. I know many times you may think of the lone bench science researcher who's working away, and that's bench science is great, but I could not accomplish all of this by myself. We were told that this was outcomes research. I think now it's called translational research. How does what we observe in the lab translate? And you say, are you observing in the lab? Yes, because we want to know, why does eating food make people feel better than feeding them this? Because this is just digested food, right? It's milk, it's a vitamin, it's some oil. What's the difference? What's going on? And so we do have bench scientists working on that. Some say it's the viscosity, it's thicker, harder to upchuck that. Some say, oh, it's all those thousands of phytochemicals that are in food that we didn't even know about 60 years ago, and that those are feeding the enterocytes of our GI tract and helping, have a better gut. We really don't know, but that's the bench science of the business. And talk about hard to do. Dr. Mundi and Lisa are collecting stool samples of people who are blended tube feeding and comparing it to when they're on formula. That's a fun study, don't you know? Yeah. All right, so we got a lot of people involved and met a lot of folks. And I did a presentation a few months back for the Australians. I had to get up in the middle of the night because their son's over there when it's not over here. And getting the word out. We had somebody from England come to the United States and visit Troy to find out about our tube feeding. Persistence and strategy are required to challenge conventional thinking and clinical practice and facilitate positive change across all aspects of nutrition support. So this type of research has led to new products being developed. When we started this, there were maybe 3, maybe 4 products available on the market. Now there are 20. Formulary development, reimbursement, trying to get insurance companies to say, you know what, this stuff is like $7, $8 a pouch. This stuff's $1.25. Yeah, but if they don't go to the hospital and you cut their meds down to 0, let's think about that. Interdisciplinary health education, getting your nurses, your doctors, your therapists on board. And then national and international practice guidelines had to be challenged as well because it said you do not put food in those tubes. These were some unanticipated outcomes. I have made so many presentations on this. As a matter of fact, Abbott Pharmaceuticals had their highest attended podcast ever when we talked about this. Had over 1,200 jump on one day, and I'm in the garage at my house and giving this talk and telling people what we experienced. So that was kind of cool. We have made BTF master classes for several pharmaceutical companies. You can still go on and watch them, how to make it, troubleshoot, who's a candidate, who isn't. This was something I'm very proud of. This came out this year. The American Society of Enteral and Parenteral Nutrition, they publish guidelines for all types of feeding, enteral, and they came out for the first time, blenderized tube feeding practice guidelines. Absolutely amazing. And our work is cited throughout. So we were able to contribute to that body of knowledge. And then the head and neck cancer paper, top cited article in NCP. So we were very proud of that as well. But here's the thing I'm most proud of. We're improving patient outcomes through evidence-based practice and research. And this is what one woman wrote when you could just do free response. One day I read the label on the can, back then we had cans, of my son's tube feeding formula, and I thought to myself, this is just corn syrup, cow's milk. I wouldn't feed that to him every day if he could eat by mouth. Why am I doing this? That's when my journey to blended tube feeding began, and it was the best decision I ever made. And she went on to say that it had been 7 years since he had a fruit or vegetable, and went on to talk about that. So the passion of these people when they realize that they don't care what the healthcare world says when they see results. And if you don't provide feeding and oversight, they will go it alone, and that's when you start getting into trouble and running into risk, especially with little kids, because their needs change as they get older. So that, to me, that's the big takeaway. I would like to think that we're helping people. And I will be happy to entertain any questions that you have. Okay. Thanks for coming. No questions? Yes?
Historian will always ask a question. Your chart that showed the progression with the downward weight spiral and the return, if it had just been tube feedings, how would that curve look?
It would
if it had been commercial food, just continuing to decline.
We have not found a single paper, at least up to 2021 we published this, that showed where weight went up. Just doesn't happen. Now that's for people who require tube feeding while they're getting head and neck cancer treatments, the chemoradiation. They usually lose 10, 20 pounds very rapidly. So that's astounding, and I really hope the Nebraska folks find the same thing that we did. Any other questions? Someone asked me the other day, what do you hope to see in the future? I said, I hope one day that when they reach for something to feed someone through a tube, it's got food in it. That's what I'd like to see. I don't want the norm, the standard. We keep calling this the standard. To me, this should be the standard. This should be what's running in the ICU and all of that. So, yes?
Are there efforts to drive down the cost of the real food pouches? Because you mentioned they're $7 to $8 versus the $1 to $2 in the formula.
That's a great question too. So I'm going to I hope I'm still right on this. This may sound political, I don't mean for it to be. But back when, in the early 1900s, when people were being inducted into World War I, they found out that we were starving as a country. And so the government, that's when dietetics was born, and they began to subsidize corn and soybean farmers, which artificially drives down the price of corn syrup and corn oil and soybean oil. And you've heard the Farm Bill. It's like the third rail of any political group, right? It's not going anywhere. It's still with us, even though we don't have a problem with that type of issue anymore. And so the things that they're using to make that are what the typical American diet is: sugar and fat. If they would stop doing that, it would probably be equivalent. So are there efforts to get this down? I don't know that we can do that, you see, because of what's going on the other end of the spectrum. What most families do what I observe is they sort of do a combo. They'll make food at home because it is very cheap. People say it's expensive to eat healthy. Get on any YouTube and YouTube the SNAP challenge, where people say, I'm going to see if I can feed my family of 4 using just the money that I would get for what we used to call food stamps. And they do it. So eating healthy is not more expensive. And many families will blend their own, and then when they go on vacations or their child's in the hospital or if they're at school, they'll send some prepackaged stuff like that. So yeah, that's how they sort of get around it. Any other questions? Yes, sir.
How do you think that this research will, the same notion, influence the public policy actually in relation to the FDA?
The public policy in the FDA?
Yeah, so basically, what do you think the future will hold based on this research, basically about the capitalism and things of that nature in regards to public policy?
That's a great question. I mean, we've got this groundswell going now. Patients want it. There's the pharmaceutical companies are providing it. If more and more people in a free market society that we're fortunate to live in keep demanding it, I feel like we'll keep going that way. That's my hope anyway. As they continue, there's lots of other papers out there, well, I won't say tons, but like there's one that Abbott did that's really good. They went in the ICU and they fed these patients a food-based, not 100% food, but I think it had about 20% food in it. They got out of the ICU so much faster. So that goes back to your question, how can you really talk about cost equivalence? It's not just apples and oranges, right? It's the whole picture. I think if we keep making the case and we keep seeing this, things will change. But we're at the beginning of it. Someone has said it takes 20 years for best practice to become best practice. For years we keep doing the same thing. This really took off about the year 2000. So we're at the very beginning of the wave, I think.
Yes. Are any companies like Abbott considering making these blended food pouches and replacing products they have like Ensure or augmenting them and maybe do it for less money?
I tell you what, the story of this one, this company was started by a mom of a child who had to be tube fed. So she started it in her kitchen, and it just grew and grew and grew. And then last summer or summer before, Teresa bought it, 3rd largest pharmaceutical company in the world, and so she's on some island somewhere living it up. But do you know what they did? They had me talk to the executives in New York to tell them what they just bought. They know that there's a market and they want to make sure they have it. There was another small company that produced a blend, but it was for like vegan. And they had another product that was sort of pre-digested, but made out of food. For your patients maybe who have pancreatitis or short gut or whatever, they bought that too. They don't even know what they have. So you have to explain what you just bought and why this is marketable. So yeah, they know it's coming, and I think they're hedging their bets, and the smaller companies are getting swallowed. So hopefully they'll keep producing it and promoting it. I also talked to somebody one time who said, well, they bought my product just so they could sit on it. That can happen too. So I'm hoping that doesn't happen. Yes?
Do you have concerns as these companies do become more commercialized that we'll see more influx of those corn syrups and those additives that we don't want to see in natural food pouches? What are your thoughts on that?
Well, thank goodness we have labeling laws. You have to say on the front what it is. And so with this, it tells you it's only food. The problem with this is it's low sodium. So you have to add salt to it. Well, then the formula companies go, oh, it's not complete, it's not complete. Ours is complete. And I would argue, well, yours is not complete because it doesn't have all the phytochemicals in it. But there's kind of the rub right there as far as reporting what's in things. Does that help? With our food labeling laws, I think we'll be protected. Mm-hmm. Any other burning questions? I love it. I created some interest in tube feeding. Yes?
You had mentioned before about the food stamps component and the tied in pieces. So piggyback on that, what do you think about any type of research looking at private pay versus Medicaid and that response to this particular problem?
Okay, so these companies, they actually have full-time employees who do nothing but help with reimbursement because it differs from state to state. So in some states, in our research where we did all over the country, and it was really heavy, like in the Northwest. They get it paid for. a little more limited down here, but we see more people blending. But that also helps inform us, what do we need to do? What do we need to focus on? If people are doing more of their blending at home, maybe we need to focus more on getting a policy in place of how to assess the home. Are they using well water? Do they have, commercially available water through our public water systems? Because that can help determine the safety of something, what they have available. So there's a lot of considerations just depending on, like you said, provider rules and getting the product. Well, thank you so much for coming and staying awake. I appreciate it. Thank you.
Trojans Talk Research is a monthly spotlight on the research interests of Troy's faculty, presented by Troy University's Office of Sponsored Programs.